we perform fundoscopy in ophthalmology? So fundoscopy is the process, anything end by E means it is the procedure. It is the procedure or the process to examine the fundus. So what is fundus? Fundus is a Latin word mean the bottom of any concave organ. And the bottom of the eye is called fundus. We have many fundi in the organ. I mean, we have fundus in the stomach, fundus in the bladder, fundus in the uterus, and we have fundus in the eyeball. So the fundus is the bottom of the concave organ, and in the eyeball, it is the bottom of the eyeball. So it is the retina, the optic nerve, and the blood vessels. So how we examine the fundus of the eye? We examine the fundus of the eye by four instruments. نعم حبيبي.
صوت الصورة راحت مال سلايدز.
يا دكتور ماكو صورة.
لحظة دقيقة خليني أسوي شير سكرين نوت له ولا زحمة عليكم. أنا أسوي شير انتاير سكرين. تمام. اوكي. يلا جعفر، وصلت عندك الصورة؟
اي دكتور هسه تمام.
اوكي حبيبي، ممنون. So the fundoscopy, it is the procedure to examine the fundus, which is, as I said, the bottom of the eyeball. So what is the bottom of the eyeball? شنو قعر العين؟ هو الretina and the optic nerve and the blood vessels. So how to examine the fundoscope? How to examine the fundus? We examine the fundus by, as I said, four instruments. The direct ophthalmoscope, the indirect ophthalmoscope, the lens with the slit lamp, which is called slit lamp biomicroscope, the lens, additional lens, condensing lens, and a special lens, contact lens, also with a slit lamp. So direct, indirect, fundus biomicroscope with condensing lens, and fundus contact lens. Sometimes we need to dilate the pupil. We need to dilate the pupil to maximize the area of the retina to be examined. As you know, the pupil is the central perforation in the iris. So if we want to examine the peripheral part of the retina, we should dilate the pupil. We should dilate the pupil by two ways. The first one is to stimulate the dilator muscle inside the iris. There is a muscle called dilator muscle. We stimulate this muscle by a sympathomimetic agent such as phenylephrine, or we block the action of sphincter muscle in the iris. We block the action of sphincter muscle in the iris called sphincter pupillae muscle by a parasympathetic antagonist agent or parasympatholytic agent such as atropine and tropicamide. So we dilate the pupil to examine the retina, the peripheral part of the retina. If the pupil is not dilated, we will just examine the posterior part of the retina. Just we maybe see the disc, I mean the optic disc and the blood vessel and the macula. This is the first instrument to examine the fundus, which is called direct ophthalmoscope. Direct ophthalmoscope. we observe and we examine the retina and the optic disc, I mean the fundus, directly. We didn't use a condensing lens or a lens, so we observe the retina directly. And this direct ophthalmoscope is a portable device. There is a batteries in the handle, in the silver handle, as you see. There is a chargeable batteries here, and this is the back view of the direct ophthalmoscope, and this is the front view. We observe the retina and the optic disc through this aperture, this perforation. We observe the retina, and there is a source of light inside the direct ophthalmoscope, so we will have an illuminated fundi. The advantage of this instrument, it is portable. I mean, we can hold this device and examine a patient who cannot sit on a slit lamp. We can examine a pediatric patient. It is easy of use. All of you can examine the fundus from the first time you hold this instrument. It gives us an upright image versus the inverted image by other instrument. We will see later on. The other instrument will give us an inverted image. What I mean by inverted image, if we see a lesion in the superior part of the image, so it is in the superior part of the retina. This is called upright image. While in inverted image, if we see the lesion in the superior part of the retina, it is really in the inferior part of the retina, because other device will give us an inverted image. يعني الصورة تكون بالأجهزة الأخرى مقلوبة. يعني إذا مثل ما قسم منكم شافوا الصورة بالستام بوحدة من الكوندنسنج لينس اللي طلعناها وشوفتها فررتكم عليها، شفت الصورة تكون inverted. بالحقيقة إذا شفنا ليجن إذا كانت الصورة inverted راح نشوفها بعدين. إذا شفنا ليجن بالsuperior part of the retina in the image, it is really in the inferior part of the retina, or vice versa. So the direct ophthalmoscope gives us an upright image. If the lesion in the superior part of the image, it is really in the superior part of the retina. The magnification of the direct ophthalmoscope is reached to 15 times the real size of the target. We can use the direct ophthalmoscope without dilatation. It has the disadvantage of small field of view. What I mean by small field of view, I mean the area of examination is small. يعني شنو? Because we have a high magnification, لأنه it has the ability to magnify the image, which reaches to 15 times. So the field of examination will be small. مثل ما عندنا صورة بالموبايل, and you want to zoom in on this image. When you zoom in on this image, you will lose the field of view. You will examine and you will see a small field of view. So because of higher magnification, the field of view is small. The second disadvantage, it has a lack of stereopsis. What I mean by stereopsis mean the sense of depth, أو الإحساس بالعمق, أو the third dimension. The stereopsis is felt because we see by our both eyes a different angle of the same object. We see a different angle, and this disparity will stimulate the sense of depth. So the sense of depth it will be created when I examine the object, when I see the object by my both eyes. So because the direct ophthalmoscope, we examine the retina and the fundus by just one eye, we will lose the sense of depth. We will lose the stereopsis. مثل ما تشوفون بالسينما تشوفون هاي ال 3D. هاي ال 3D انه احنا لازم نشوف باثنين عيوننا، نشوف الزاوية مختلفة من الأوبجكت. هاي الزاوية المختلفة يسموها retinal disparity. The retinal disparity of the same object will stimulate the sense of depth, الإحساس بالعمق. Our brain has the ability to fuse those images from both eyes and give us the sense of depth. So the direct ophthalmoscope, because we examine just by one eye, there is no sense of depth. The third disadvantage is called the media opacity can degrade the image. If we have a media opacity, media I mean the media of the light. The light passes through ocular media, I mean through the cornea, through the anterior chamber, through the pupil, then the posterior chamber, then the lens and the vitreous. Any opacity in this media, I mean the media of the light, the image will be of low resolution. This is the parts of the head of the direct ophthalmoscope, and you will see that there is a viewing aperture and there is a wheel inside, beside on the side of the head, will control the length, the strength of the lens. I mean, we can use a plus lens or a minus lens, +1, +2, +3, or 0, or -1, -2, -3, and so on, according to the refractive error of the examiner and according to the examination maneuver. And we will see later on what I mean by that. This is another image of the direct ophthalmoscope. How we examine by direct ophthalmoscope? We firstly observe what is called the red reflex. All of us have, normally we have what is called a red reflex. This is a normal phenomenon caused by the reflection of the light from our fundi. So the reflected light from the retina and retinal blood vessels and the underlying choroid, the light will be reflected red. It's called a red reflex. It is the reflection of the light from our fundi. It is normally of red color because the color of the blood vessels of the retina and the choroid and the underlying choroid. So it is red, normally red. If we notice any abnormalities in this red reflex, I mean, if the reflex is abnormal color or there is any abnormal opacity, as we will see later, this is maybe an indication for underlying disease. So firstly, we should observe the red reflex by the direct ophthalmoscope. How we observe red reflex? We should observe the red reflex by, like this examiner who is about 1 foot away from the eye of the patient, and as you see his finger on the lens strength wheel, he put the lens strength wheel on a +6 or a +10, and he is off of the patient axis. I mean, not directly. He will be slightly oblique by a 10 to 15 degree. And he observed the reflection of the light which come from the head of the direct ophthalmoscope, go the light to the retina of the patient, then reflect it backward, and he observed the reflex. And you will see the normal red reflex. This is the normal red reflex. All of us have normally a red reflex. وهماتين تشوفون بالصور إذا واحد يستخدم فلاش تشوفون مثلا واحد بالصورة تصير عينه حمراء، فهذا عينه حمراء هو normally إنه يكون ال pupil, the reflection of the light from the pupil is red. This is normal. ليش واحد بالصورة يصير هيك والبقية لا؟ As I said, there is a special situation. You should be slightly oblique to the eye of the patient, and you use the light. In special situation, the red reflex will appear, and you will notice the reflection of this light. If there is any opacity in the media of the light, I mean, if there is opacity in the cornea, any opacity in the lens, for example, there is opacity in the lens, any opacity in the vitreous, will obscure or will give us an abnormal red reflex. So this is an abnormal red reflex. As you know, there is opacities inside the red reflex. This is due to cataract. Also, you notice in the up image on your left side, there is also opacity in the red reflex. On your right side, you notice also abnormal red reflex. This is due to subluxation of the natural lens inside the eye of the patient. يعني العدسة, lens inside the eye of this patient is subluxated, يعني مخلوعة. It is of abnormal position, and you notice the margin of the lens. You notice the margin of the lens going into the central part of the pupil. In the lower image, you notice this child with an abnormal right eye red reflex. It is of white color. So this is a white reflex. White reflex is called leukocoria. So leukocoria mean a white pupil. Leuko mean white, like leukocytosis or leukocyte. It mean white. Coria mean pupil. So leukocoria mean a white pupil. Leukocoria or white pupil, it has a many differential diagnoses, but the most important to keep in your mind, the first two important differential diagnoses, which is the congenital cataract and retinoblastoma. So if you notice a child with abnormal red reflex, I mean, if you notice a white reflex instead of red, this is a leukocoria. You should keep in mind to exclude a major ophthalmic disease, which is congenital cataract and retinoblastoma. Retinoblastoma means a tumor originating, a malignant tumor originating from the retina. So retinoblastoma can present with leukocoria, I mean white reflex rather than red reflex. And when you dilate the pupil to examine the fundus, I mean to examine the retina, the optic nerve, and the disc, you will notice a whitish lesion sitting on the retina, which is the retinoblastoma. So you should keep in mind that abnormal red reflex may be caused by retinoblastoma and congenital cataract. After you observe the red reflex, you should go and approach more closely to the patient to follow the red reflex until you catch the image of the retina. And you can move right and left, up and down, and you can ask the patient to move his eye to the side gaze to examine the peripheral part of the fundus. Once you catch the retina, you should have a system in examination of the retina. You should observe and examine the disc, the blood vessels, and the macula. Then you go to the peripheral fundus. This is all about direct ophthalmoscope. So the first instrument is direct ophthalmoscope. The second instrument is indirect ophthalmoscope. Indirect ophthalmoscope, this is the shape of the device called indirect ophthalmoscope. By indirect ophthalmoscope, we examine the retina indirectly by using a condensing lens. We use additional lens. We will see later on. This is the lens held by the hand of the examiner in front of the eye of the patient to form an image by this condensing lens between the examiner and the lens to be observed by the examiner. فالindirect ophthalmoscope هذا اللي تشوفوه الاكزامينر يلبسه هيك براسه واكو source of light. اللايت هذا goes to the retina and the optic disc and the blood vessel, then will be reflected backward. The reflected light will be condensed and will be focused by this condensing lens to form an image. The image will form here between the examiner and the lens, and the examiner will see the image of the image reflected from the retina, which is this process called indirect ophthalmoscopy. The indirect ophthalmoscopy, mostly it is binocular. Binocular means we examine by our both eyes, or sometimes monoocular. The advantage of the indirect ophthalmoscope, it has a wide field of view because of lower magnification, which is one of its disadvantage. So we have a wide field of view, and because we examine by our both eyes, so we will feel the sense of depth. We will have the stereopsis. As I said, because we have a wide field of view, we will have a decreased magnification, and it requires more skills. You need more training on indirect ophthalmoscope. This is this second disadvantage. You need more training to catch the image of the fundus by the indirect ophthalmoscope. While direct ophthalmoscope, I'm sure you are from the first time we will catch the image of the retina. We have previously, before the COVID-19 pandemic, we will have one activity in the ophthalmology to examine the fundus by direct ophthalmoscope, but because, as you see, the examiner will approach very closely to the patients, this activity was cancelled. The third disadvantage by indirect ophthalmoscope, it gives us an inverted image. As I said, this is versus the upright image by the direct ophthalmoscope. The inverted image, because we use a condensing lens, a plus lens. This plus lens will give us a real and inverted image. Real image mean an image which can be captured by a screen. Inverted يعني صورة مقلوبة. بالحقيقة إذا شفنا الليجن بالصورة إذا شفنا الليجن on the inferior part of the image, really it is on the superior part of the retina and vice versa. The fourth disadvantage, it requires pupillary dilatation, so we cannot examine the retina and the optic disc clearly with undilated pupil. We need to dilate the pupil by agents that stimulate the sphincter, the dilator pupillae, or block the action of sphincter pupillae muscle. This is the process of indirect ophthalmoscopy. The third way to examine the fundus, as I said, with a slit lamp, and by slit lamp we need additional lens, additional condensing lens. We have a variable power. As you see here, we have one lens have a power of 78 diopter. Another, we have 90 diopter condensing lens. Another, we have 60 diopter condensing lens. So these lenses condense the light and focus the light which come from the fundus, from the retina blood vessels, parallel to form the image between this is the process and the procedure to form the image between the slit lamp and the lens to be observed by the examiner. The field of view and magnification is variable according to the lens and slit lamp magnification. It gives us also an inverted image like the indirect ophthalmoscopy, and we will feel the sense of depth because we examine the fundus by our both eyes, and we need also more skills, and we need a dilated pupil, also the same as indirect ophthalmoscopy. This is the procedure. The patient put his head on the forehead strap and on chin rest, and the examiner put the lens in front of the eye of the patient, and the slit lamp will give a light rays to the retina, which will be reflected backward and condensed by this condensing lens to form the image which will be seen by the examiner. The fourth way to examine the fundus is by what is called fundus contact lens. By fundus contact lens, we use a lens which will be applied to the eyeball after we put a topical anesthesia. نخلي قطرة تخدير بعين المريض ونخلي هذه العدسة اللي هي contact lens after we put a coupling agent, transparent coupling agent, like a gel-like substance called methyl cellulose. نخلي قطرة تخدير بعين المريض ونخلي methyl cellulose اللي هو coupling agent like a viscous fluid on the contact lens, and then we put this fundus contact lens on the cornea of the patient. Really, it is it causes some discomfort for the patients, but it is necessary for special examination maneuver and special surgical interventions. For example, if a patient come with he feel that he have some flutters and photopsia. I mean by flutters, something fly in and he's something flying in his field of view. يحس مثلا خيط يطير بعينه أو مثلا يقولون مثلا أكو هيك شعراية بعيني تمشي. هذه يسموها flutters. Photopsia mean flashes of light. يشوف ضوء يغمض بعينه. فهذه flutters and photopsia maybe it is a sign of posterior vitreous detachment. The vitreous inside the eyeball may be detached from the retina. In this situation, we should examine the extreme periphery and all over the retina. The retina and the extreme periphery of the retina cannot be examined by other way. I mean by the condensing lens, by the direct ophthalmoscope. It should be examined by the 3-mirror contact lens. By this lens, we have a mirror, like in this real lens, we have mirror. This mirror will reflect the image of the retina on the opposite side. فهذه الصورة تعكس صورة الرتنا بالجهة المقابلة، وهاي الميرور تعكس الإيمج بالصورة المقابلة لها، وهكذا. فعندنا 3 mirrors، كل مراية تعكس صورة الرتنا المقابلة إلها، وكل مراية لها زاوية معينة. هم خالين كل مراية لها تعكس صورة معينة أو جزء من الرتنا، وإحنا هذه ال3 mirror إحنا راح نفرها on the to examine all parts of the retina. To examine all parts of the retina and extreme periphery of the retina, we should use this special contact lens, which is called the 3-mirror contact lens. For example, if we found a tear or retinal break and we want to apply laser for the peripheral part of the retina, we should use the 3-mirror contact lens. As I said, when you examine the retina, whether by direct, indirect ophthalmoscope, slit lamp with condensing lens, or fundus contact lens, you should have a system. You should observe, first of all, the optic disc. What we see by the optic disc, we will see the margin of the optic disc. We will see the margin of the optic disc. If the margin is well or less demarcated, then we will see what is called the neuroretinal rim. The optic disc have 2 parts. The peripheral part called neuroretinal rim, and the central part called the optic disc cup. So we have rim and cup. Then we observe the blood vessels we observe the blood vessel which have a wider diameter and more dark red color. It is the vein. And the blood vessel which has a narrow caliber and more brighter in color, this is the artery. Then we should observe the other part of the retina, and we observe the central part of the retina, which is very important for the central vision. It's called the macula, which have the highest concentration of the photoreceptors, the cones and rods. So this is an illustration for the fundus. We have two parts of the disc, the rim and the cup. Why we have this distribution, why we have the shape of what's called the cup and the rim? You know that the optic disc, it is the beginning of the optic nerve. The optic disc is formed and the optic nerve is formed by the nerve fiber, which is coming from all over the retina. In the retina, we have a layer called nerve fiber layer. The nerve fiber layer sends its fiber in the direction of the optic disc, and all these nerve fiber, which have the number of 1.2 million, will gathered to form the optic nerve. The beginning of the optic nerve called optic disc. The distribution of nerve fiber is not even. I mean, it is not equal in all part of the optic disc. So it is more condensed in the peripheral part, which is called rim, and it is less in the central part, so it will form a depression, which is called cup. So we have a rim and a cup. As I said, we have vein, and we have artery, and we have macula, then we have the peripheral part of the retina. ف one of you خلينا نشوف آمنة سعد. Hello آمنة. So unmute and describe this fundus image. آمنة سعد فؤاد. So آمنة ما موجودة. يلا آمنة عيسى.
نعم دكتور.
آمنة عيسى. آمنة, describe this image please for me.
دكتور اللي هي normal fundus with a clear
Yes, this is an image.
demarcation of
Okay.
no.
This is fundus image. Okay, this is an image for the fundus, and you start with the disk. So you have a system and go on.
With a clear demarcated optic disc.
شكرا آمنة. Amna started with the optic disc, and she said that the disc is well demarcated. زين. شكرا آمنة عيسى. يلا آية أحمد. Can you complete the description of the optic disc? آية أحمد علوان.
نعم.
يلا آية أحمد. آية أحمد هي قالت آمنة إنه we have a well demarcated optic disc وكلامها كلش مضبوط. فأنتِ راح تكملي لنا another description of this optic disc.
Central cup and the normal neuroretinal rim.
Yes. آية أحمد شكرا إليش. She said we have a normal central cup and a normal neuroretinal rim because she said and she noticed that neuroretinal rim has a normal color of orange to red in color, and the central part of the cup is small and it is of whiter and yellowish to whitish in color. شكرا آية أحمد. يلا أنفال مظهر.
نعم دكتور.
نعم أنفال. خلاص هم قالوا أكو well demarcated وقالوا أكو rim, then you should continue another.
دكتور blood vessel.
Yes.
يعني
واضحة.
أنفال تقدرين بس شوية تعلين صوتك؟
نعم دكتور.
نعم.
دكتور
يلا البلاد فيسل ايش بيها؟
الفين هي larger وداركر
صح.
والارتري smaller وبرايتر.
Yes, we should know that the vein and the arteries, um, and we should know if there is an abnormal blood vessel. This is the normal distribution. If we see an abnormal blood vessel tuft on the optic disc, this is you will see later on with other lecture. If you see a tuft of blood vessels on the optic disc, this is maybe a neovascularization. A neovascularization may be due to diabetic or something else. This is abnormal, and this patient may be liable for hemorrhage. So you should know and you should describe the blood vessel. شكرا أنفال. يلا أهلا ياسر. Continue the description.
دكتور يعني there is no signs of hemorrhage يعني سواء flame hemorrhage or blood and dot hemorrhage. There is no atrophy of the veins.
Thank you.
و-
شكرا. Okay, تمام. She looked to the peripheral part of the fundus, the retina, and she noticed that there is nothing to be mentioned about an abnormal finding. So we should go to the next image. شكرا أهلا. يلا إيان أو أيان عبد الحسين.
دكتور بس العفو بالنسبة لسؤال الصورة اللي قبلها.
نعم بس قولي لي اسم حضرتك لأن أنا ما دابا على اسمها.
أمنية.
يلا أمنية.
دكتور بس هنا بهاي الصورة مال الفندس اند الديسك هنا المفروض إنه ما بين الماكيولا مو صحيح؟
صح. The macula is not so clear. It is on your left side. So the macula, if you see my cursor, صح. This is the area, the darker area, because the disc is appear centrally. The macula on your left side. So if you see my pointer, this is the area of the this is the area of the macula, and you are right. You will see later on the site of the macula, like this is the site of the macula. It is on your right side. It is between the arcade. This is called arcade, the blood vessel called arcade. So we have superior arcade of vein and artery and inferior arcade of vein and artery. Between of them, they embrace the macula. The macula centrally have area which is avascular, which is called foveal avascular zone. فالماكولا هي بين superior arcade between the superior and inferior blood vessel. فهنا همتين تكون الماكولا between the superior and inferior vein and artery. This is the site of the macula in the central area. Okay. يلا أيان.
نعم دكتور.
Hello. أيان مكتوب optic disc edema فالتشخيص واضح بس احنا ما نريد نعرف التشخيص لأنه هو مكتوب نريد your description. how to describe this image.
هي اثنينهم.
Yes, both of them. Any one of مثل ما بدت آمنة شلون بدت آمنة you should start like آمنة عيسى.
نقول إنه ال optic disc not clear demarcated.
Yes, you are right. You should say and you said that the optic disc is not well demarcated. You cannot tell where is the margin of the optic disc. فإحنا ما مبين ما نعرف بالضبط حدود الأوبتيك ديسك وين. it is not well demarcated. شكرا أيان. يلا آية حسين. آية حسين.
نعم دكتور. نعم دكتور.
يلا آية. فهي قالت أيان إنه the disc is not well demarcated or hazy margin of the disc and this is the first sign of optic disc edema. And you should notice the another sign, which is clear by the image.
optic disc swelling
Yes. نعم.
والبلد vessel hemorrhage.
Yes, you notice that we have hemorrhage in your left side image. We have hemorrhage inferiorly, and on your right image, the hemorrhage, it is on the temporal side. So this is the second sign of optic disc swelling. Shukran, Aya Hussein. This is the second sign. We have a splinter or flame-shaped hemorrhage near the disc or over the disc. So this is another indication that the disc is swollen. Another sign of optic disc swelling is the engorged blood vessels, not so clear here. And the fourth sign is the central cup, the central depression of the optic disc, which is called the physiological cup, is so small or it is obliterated. All of you should notice that the cup, it is not so clear like in this image and like in this image. So this is the cup normally, while in optic disc swelling, because there is fluid inside the optic nerve, then the depression is small and the fibers is distributed, so the optic disc cup is obscured. So this is another indication that the optic disc is swollen. The fifth sign, which is not seen here, it is that you notice if you examine really the patient by your both eyes in a slit lamp or by indirect ophthalmoscope, you will see that the optic disc is really bulging because you will feel the sense of depth. إذا تفحص بالسlit lamp راح تشوف الoptic disc is bulging toward you inside the vitreous because you will have the sense of depth. You will have the 3D dimension. So this will be lost by the two-dimensional image in this picture. The optic disc swelling is caused by many diseases. For example, it may be caused by rise of intracranial pressure. Another cause of optic disc swelling is by malignant hypertension. Another cause of optic disc swelling is optic neuropathy. I mean, whether there is optic neuritis, or if there is optic nerve ischemia, or whether by hereditary disease, or maybe due to traumatic, or maybe due to infiltrative process, like in sarcoidosis, or maybe due to tumor, and so on. So there is many causes of optic disc swelling or optic disc edema. One of them, as I said, the rise of intracranial pressure, rise of ICP. So you should not say that the disc swelling is synonymous to papilledema. Optic disc swelling, which is caused by rise of ICP, is called papilledema, while optic disc swelling is caused by rise of ICP and many other causes. So just when you examine the cause of optic disc swelling and you notice that this optic disc swelling due to rise of ICP, you should say that this is papilledema. So papilledema is disc swelling which is bilateral due to rise of ICP, whether due to space-occupying lesion or whether due to idiopathic intracranial hypertension or so on. Yalla, Ahmed Muhammad, describe this fundal image in front of you.
دكتور نبدي بالاوبتيك ديسك. هذا الاوبتيك ديسك clear demarcated optic disc.
في عليك clear demarcated well demarcated تمام.
well demarcated optic disc والكلر مالته يعني شلون يعني more white or pale.
صح كلامك مضبوط. So شكرا أحمد. فأحمد هو قال it is a well demarcated optic disc. Well demarcated optic disc and its color seems to be more whitish in color. لونه صاير أبيض أو أصفر. So this is a sign of optic disc atrophy. Optic disc atrophy, we have two types, whether it is a primary, I mean without previous optic disc swelling, or secondary due to previous optic disc swelling. You will take a lecture about optic atrophy. But these are the sign of optic disc atrophy, which is primary. It has a well demarcated and chalky white color. لونه هيجي chalky white like لون طباشير لأنه كلش أبيض due to loss of the nerve fiber, loss of this of the viability of the optic nerve. You will have a more whitish color optic disc. So well demarcated and chalky white optic disc is a sign of primary optic atrophy. شكرا أحمد. As I said, we have what is called optic disc cup. The optic disc cup is normally present in all of us. We have this normal distribution of neuroretinal rim and cup, but the size of the cup should not exceed a 30% from the total vertical diameter of the disc. If this size, I mean, of the cup is more than 30% of the total vertical diameter, we should regard this optic disc as suspicious. We should search for the signs and the criteria for glaucoma, because any patient who have large optic disc cup, this may be a case of a glaucoma unless he have a normal intraocular pressure, a normal visual field, I mean a normal other parameter. And if the patient have a large cup and all parameters are normal, we may regard this patient as a normal variant of large cup, because we have rarely a 2% of normal population who have a large optic disc. But this is rare. If you notice that the disc cup is large than 30%, you should search for the another parameter of the glaucoma. So you should measure clinically the size of the optic disc. And you notice that on your left side راح تقول لنا آلاء رحيم آلاء راح تشوفين مثلا هذا الأوبتيك ديسك وهذا الأوبتيك كاب. الأوبتيك ديسك كله اللي محاط باللون الأخضر، والأوبتيك ديسك والأوبتيك كاب هو المحاط باللون الأزرق، والبينات بين اللون الأزرق واللون الأخضر هاي النيوروريتينال ريم. فأنت راح تقولين آلاء رحيم راح تقولين إن هذا الكاب إيش قد تنطين percent from the total vertical diameter of the disc.
دكتور يعني هو هنا تقريبا نورمال يعني 30.
خليني أنا راح أطلع لك صورة ما يخالف. راح أطلع لك مثلا هاي الصورة اللي هو هذه ولا هاي. هذه الصورة بتشوفين الأوبتيك ديسك كاب، تشوفيه هو هذا السنترال اريا اللي هي لونها هيك صاير أصفر، وحولها أكو نيوروريتينال ريم. أوكي، هاي السايز مالتها السايز مال الأوبتيك ديسك إيش قد، خليها ببالك وشوفي هذا، وشوفي مثلا هاي الصورة، شوفي الأوبتيك ديسك هذا السنترالي السمول وايتش اريا، هاي السنترالي، وشوفي النيوروريتينال ريم شلون صايره، ايش قد الحجم مالتها، وشوفي هذا الاوبتيك ديسك كاب. شوفي الاوبتيك ديسك كاب، انت قارني طول الاوبتيك ديسك كله من هنا لهنا، وقارني طول الكاب من هنا لهنا، ايش قد طول هذا الكاب الى طول الديسك، يعني هل هو طول الكاب الى طول الديسك ربع لو نص، لو 3/4، لو هو الكب بطول الديسك، انت شنو تنطين نسبة؟
يعني تقريبا شوية أصغر من الديسك.
يعني ايش قد، يعني ايش قد من طوله؟ يعني طوله 30%، طوله 40%، 50%، 60%؟ لو لا يعني ما تقدر تنطين، صعب عليك.
تقريبا
اوكي شكرا
90.
آلاء. خلينا نشوف آلاء فلاح. آلاء تقدرين تقولي لي ايش قد طول الكب الى طول الديسك كله؟ يعني طوله
دكتور تقريبا
10%،
فد
لو
يعني
20، لو
مثلا
30؟
7/10، 7/10 أو 8/10.
انت رحتي للاصعب، صحيح كلامك، تقريبا 7 الى 8/10، بس تقدرين تقوليها بالمية حتى يفتهمون زملائك؟
يعني 70 أو 80%.
صح. طول الكب تقريبا محتل من طول الديسك، يعني اكثر من النص، 70 80% تقريبا. يعني هي لاحظت آلاء فلاح انه تقريبا الكاب هذا اللي هو محاط بالازرق، اللي هو more whitish in color، تقريبا اكثر من النص. فهي قالت 70 الى 80%، وكلامها صحيح. ف راح تكملي معنا آلاء. تشوفين آلاء الديسك اللي على ايدك اليسار، الكب مالته اللي هو سنترالي، مهم انت راح تقولي لي تقريبا ايش قد محتل من الديسك، يعني برايك.
هنا تقريبا إنه فد 40 أو 50%.
زين عافيه. على ايدك اليمنى؟
هنا أزيد من النص بشوية، إنه
صح،
هم 60 أو
اكيد
70%.
ازيد، لانه انت شفتي انه على ايدك اليسرى اصغر من على ايدك اليمنى، فدا نشوف انه فدا نشوف انه الكب از لارجر. ليش هذا الكب؟ احنا ليش يجي حكينا هوايه على هذا الموضوع؟ لانه هذا الكب if it is large it may be this a sign of a serious and a major disease in ophthalmology called glaucoma. So this is maybe a sign of optic disc damage. شكرا آلاء فلاح. So one of
دكتور يعني الصورة،
نعم.
يعني الصورة الأولى كانت يعني كديفرنشال diagnosis إنه glaucoma.
Yes, this patient.
Sign.
Yes, this patient may be glaucomatous because glaucoma, it is a collection of criteria. We should not say this is a glaucomatous patient by just seeing the optic disc cup. We should collect other criteria of glaucoma, which is the intraocular pressure, visual field, we assess the angle of the anterior chamber, and we assess the patient by a device called optical coherence tomography. So we should search for another sign. We should search for another sign. But if we see a large cup like in this picture, and we notice that the intraocular pressure is normal, and the visual field is normal, and the OCT is normal, and the anterior chamber angle is normal, and we follow the patient after 6 months, after 1 year, and there is no change, we may regard this patient as a normal variant. As I said, there is a 2% of patients have optic disc cup, which may reach to 0.7 from the total vertical diameter. Okay, شكرا. زين. So this is optic disc cupping, which is one sign of glaucoma. يلا أماني صديق, describe this image.
نعم دكتور. First, we have a clear margin of optic disc.
Yeah.
The cup to disc ratio look normal.
عافية. ايش قد يعني تقريبا تنطين هذا الكاب تو ديسك ريشيو اللي هي يسموها سي دي ريشيو، كاب تو ديسك ريشيو، كلامك مضبوط.
20%.
يس تقريبا 2%، كلش صغيرة. فأنت اعطيتيها 20، يعني تقريبا 20، وكلامك كلش مضبوط. شكرا لك. يلا نشوف أمنية رافد.
نعم دكتور، هسه ورا ما خلصنا الأوبتيك ديسك نشوف البلود فيسلز. اللي هي الفينز والارتريز و they look normal. There is no tortuosity.
تمام. اوكي شكرا. يلا امين قاسم. امين.
نعم دكتور.
يلا امين تقدر تكمل. you describe this image. طبعا هو مكتوب exudate diabetic retinopathy but I want you to describe.
دكتور there is yellowish discoloration in the peripheral field of the retina.
صح. There is yellowish discoloration. There is yellowish lesions scattered around the area of the macula. So these yellowish lesion, شكرا أمين, is called exudate. And this exudate can happen in various ocular disease. One of them, and the most common cause, شكرا أمين, is diabetic retinopathy. So this whitish lesion, yellowish lesion, is called exudate. The site of this exudate near the macula, this is the area of the macula, and the central area of the macula is called fovea. So this is the fovea. It is not involved by the exudate, while it is the exudate surround the area of the fovea. These exudate are the constituent of the blood. It is lipoprotein, which is leaked from the abnormal blood vessels because the diabetic patients have an abnormal blood vessel which may be leaky, and it may leak the lipoprotein which accumulate inside the retina, causing what is called exudates. So these are exudates in the diabetic retinopathy. Yalla Amin Karim, can you describe this image for me, please?
دكتور clear margin مال optic disc.
صح. Amin, you should describe this image totally. أنت هسه بعد you are experienced.
اوكي دكتور مال optic disc الكاب ما واضح كلش.
صح، عفي عليك، مو كلش واضح لانه الصوره الايمج هو الكابتشر مالتها ماخذين اللايت كلش عالي فما كلش واضحه. اوكي skip it.
والماكولا is dark.
Yes, you skip the blood vessels. Okay.
دكتور بعد
you see
normal.
obviously yes.
blood vessel normal والماكولا dark.
Yes, high area of the macula is darker in color. We have 3 or 4 causes of dark macula. شكرا أمين. Because there is high concentration of photoreceptor here, and there is a pigmentation and pigments called lutein and zeaxanthin here, and because the area of retinal pigment epithelium, there is layer in the retina called retinal pigment epithelium. In this area, the retinal pigment epithelium is more taller. So the retinal pigment epithelium, it's called pigment. So it has pigment because it is more taller in this area. The area of the macula is pigmented. So the macula appear dark. But I mean, he missed the major lesions in the retina. راح يقول لنا إياها أنور أحمد. يلا أنور.
نعم دكتور، تسمعني؟
نعم أنا أسمعك واضح جدا.
دكتور بقى أكو هيموريج وأكو الإكزوديت.
صح. شكرا أنور. There is exudate scattered in the retina, and there is hemorrhage. And we have 2 types of hemorrhage here. We have inferiorly, as you see, area of hemorrhage, which is called a flame-shaped hemorrhage. يعني hemorrhage مثل اللهب, flame-shaped. ليش صاير هيك شكله؟ Because the hemorrhage occur in layer of retina which is called nerve fiber layer. We have 10 layers in the retina, 10 طبقات. One of them is called nerve fiber layer. as I said, the nerve fiber send its fiber in the direction of the optic disc to be gathered to form the optic nerve. So the hemorrhage occur in this nerve fiber, and it will take the shape of the nerve fiber layer. So it will take what is called the flame shape hemorrhage. And we have another hemorrhage here scattered like a dot. So this is called dot and blot hemorrhage. So we have dot blot hemorrhage and we have a flame shape hemorrhage. So if you see an exudate, dot blot hemorrhage, flame shape hemorrhage, this is mostly a case of diabetic retinopathy. يلا أوس أحمد. Can you describe this image please?
نعم دكتور.
شلونك أوس؟
Yeah, دكتور. دكتور, first the optic disc. This is image of fundoscopy. The optic disc margin is well demarcated, clear line. The optic cup not okay, يعني kind of clear, but which is small. يعني
شكرا
30.
أوس. تمام أوكي شكرا إلك. يلا آيات حمد.
أي نعم دكتور. abnormal blood vessel. أكو tortuous بالvein وأكو dark matrix.
vein is more tortuous. شكرا آيات. The آيات look to the vein and she noticed that the vein are more tortuous. So حتكمل لنا آيات عباس.
نعم دكتور.
يلا آيات. قالوا زملائك انه الاوبتيك ديسك وقالوا وحكوا على البلد فيسل مور تورتشوس. وكملي لنا آيات.
اكو flame shape hemorrhage وبلوت hemorrhage.
Yes, there is a flame shape hemorrhage. You notice that the hemorrhage flame shape, all these hemorrhage شكرا آيات, all these hemorrhage look to be directed to the site of the optic disc. This and there is a dot blot hemorrhage, as Ayat Abbas said, because this case is caused by central retinal vein occlusion. So there is vein occluded which drain the blood from all over the retina. So the vein that is draining the blood from all over the retina is blocked, and the blood will stay in the vein. So there will be a dilatation and tortuosity of the vein, and some of the vein and capillaries will rupture to form a hemorrhage inside the retina. And if the hemorrhage in the nerve fiber layer, it will take the shape of flame shape. If the hemorrhage is deeper inside the retina, it will give us a dot and blot hemorrhage. زين. راح تقول لنا آية أحمد آية what we mean by fundoscopy آية أحمد.
نعم دكتور.
شلونك آية؟
الحمد لله. دكتور يعني
what we mean by fundoscopy.
دكتور يعني نسوي examination للinner part of eyeball اللي هو الرتنا والبلد فيزلز.
yes شكرا. يلا آية حسن. ممنون آية أحمد. يلا آية حسن.
نعم.
يلا. How can you give me one instrument to examine the fundus?
The fundus يعني غير direct.
Yes, direct ophthalmoscope. Direct ophthalmoscope. Yes, يلا آية حيدر. Give me a second instrument to examine the fundus.
لا دكتور ما سمعت الاسم.
آية حيدر.
اي نعم دكتور.
يلا آية give me a second instrument to examine the fundus.
Fundus biomicroscopy.
Yes, fundus biomicroscopy اللي هو شنو هو هذا الفندس biomicroscopy؟ تقدرين تقولي لي شنو هو هذا؟ شلون يعني شنو هذا؟
شنو دكتور بس الصوت مو واضح.
أنا أسألك الفندس بايومايكروسكوب اللي أنت قلتيه، أريد تشرحي لي شنو يعني فندس بايومايكروسكوب، يعني شو نسوي؟
We use a slit lamp with condensing lens.
عفيك تمام. المريض بالفندس بايو مايكروسكوب. بايو مايكروسكوب يعني نقصد بيه السليت لامب. شكرا آية حيدر. تمام. يعني المريض نستخدم سليت لامب والمريض يخلي راسه على التشين ريست ونخليه كوندنسنج لينس. شكرا. يلا جعفر خلينا نشوف لك سؤال. جعفر حامد. جعفر هو انت اللي اتصلت عليه لو جعفر عبد الوهاب؟
دكتوراني.
تمام جعفر اوكي عاشت ايدك. شكرا لتواصلك. جعفر can you tell me what is this lens؟
دكتور نسيت.
Okay, I will give you a second chance. يلا جعفر. Give me just describe the lower image. جعفر. Describe the image of this child.
دكتور هاي صورة للريد ريفلكس
عفية.
اللي هو النورمال عند الناس العاديين. بس
صح.
هاي العين اليمنى ما بيها ريد ريفلكس.
صح.
فممكن كاتاراكت وممكن هذا التيومر ريتينوبلاستوما.
ممنون شكرا. هذه الساين. شكرا جعفر عبد الوهاب تقدر تقول لي شنو اسم الساين هذا الوايت ريفلكس لو صعب عليك؟ جعفر عبد الوهاب تسمعني؟ جعفر ما موجود؟ جعفر ما موجود. اوكي يلا حسان صفاء. حسان.
نعم دكتور.
حسان وياي؟
نعم دكتور.
نعم حسان تقدر تقول لي الوايت ريفلكس الى اسم بالعيون، شنو هو الاسم؟ انا قلته انت تتذكره لو صعب عليك.
دكتور هذا الريتينوبلاستوما؟
صح. الكوز congenital cataract or retinoblastoma. بس انا ما سالت على الكوز، انا سالت على اسم الساين اوف وايت ريفلكس.
معناته هذا مال ريد اوبزرف شو اسمه يصير وايت، بس ما اتذكر بالضبط الاسم دكتور والله.
زين اوكي. can you describe the image on the top image on your right side؟ الصورة الفوق وعلى اليمين شنو هذه الصورة؟
دكتور هذا البيوبل عن اللينس متحرك.
يعني شنو المتحرك بالضبط؟
دكتور اللينس صار بالسنترال تقريبا.
صح. فاللينس متحركة. اللينس صايرة
متحركة. نعم.
عفية صحيح. شكرا حسان. أنا سؤالي كان عن الوايت ريفلكس يسموه لوكو كوريا. شكرا حسان. يلا حسن عبد الهادي. حسن سوي اني ميوت. جعفر عبد الوهاب ما موجود. حسن عبد الهادي. ماكو حسن. يلا حسنين أسامة.
نعم دكتور.
شلونك حسنين؟
أهلا وسهلا.
حسنين تقدر تقولي هذا شنو اسم الديفايس؟
دايركت اوفثالموسكوب.
شكرا حسنين. يلا حسنين حامد.
نعم دكتور.
حسنين احنا سألنا على هاي اللينس اللي انا طلعتها لجعفر، تقدر تقول لي اسمها لو صعب؟
دكتور انا ذكرت في ميرور استخدمها بالفندس كونتاكت لينس. انواع الاستخدام.
عفي انت قلتها. عفي عليك. عفي. هذه شنو اسمها؟ تقدر تقولها لزملائك نوبة اللغة؟
دكتور فندس كونتاكت لينس نستخدمها وإلستت لامب على مود نحصل فحص
شنو به هاي الكونتاكت لينس؟
دكتور 3 ميررز، يعني أنا مودي نشوف
صح،
البريفري
بيها
مال
3
الريتنا.
mirror. Yes to examine. شكرا حسنيا. تمام. يلا حسين. Why we want to examine to dilate the pupil? Why we want to dilate the pupil if we want to examine the retina?
دكتور to visualize the peripheral retina.
شكرا. زين تقدر تقول لي how we dilate the pupil? How we dilate the pupil by which agents?
دكتور اكو اثنين اللي هن الباراسمباثوليتيك اور سمباثوميميتيك. السمباثوميميتيك اللي هو
شكرا
فينولفين.
حسين.
كمل ولا؟
تمام كلش ممنون منك. شكرا. أنا أشكركم جدا. خلاص السيشن مالتنا هو سيشن قصير. بس أحب أعرف إذا أكو أحد عنده سؤال. أنا حاضر.
بس العفو.
نعم. قولي لي اسم
بالنسبة
حضرتك.
آية حسن.
آية. يلا آية. هسه إحنا عندنا آمنة سعد ما سمعنا صوتها، وجعفر عبد الوهاب، مو صحيح؟ يلا آية اسأليني. نعم.
دكتور بس أخير صورة.
إيه. صورة
يعني
السنترال
هو الديسك well demarcated، بس أنا يعني هو لازم يكون إنه perfectly round، لأنه أنا مثلا من الجهة اليمين شوية فلات أو من الجهة اليسار بيكون مو كلش، يعني بدي أشوف أنا perfectly round يعتبر normal.
اوكي. هو طبعا in patient with central retinal vein occlusion the disc may be edematous, and you are right. The sometimes the disc is swollen, and if you see another cases because the area of because the severity of the occlusion is different, so we have sometimes what is called non-ischemic central retinal vein occlusion. And if the occlusion, I mean, if the thrombus is severe, so we may have a severe retinal vein occlusion, which is called ischemic type. So we have non-ischemic central retinal vein occlusion and ischemic central retinal vein occlusion. So we have different severity in central retinal vein occlusion, and you may see a different picture. So if you search in Google and you write CRVO, I mean central retinal vein occlusion, you may see a different picture according to the severity. In this image, you see, as you said, there is area of hazy superiorly and inferiorly, and you are right. But the aim and the object of this lecture is not to diagnose the central retinal vein occlusion. My aim here is just to put in your mind how to describe the image and how to examine the image and how to talk about the image. Later on you will have a lecture which is called loss of vision. راح يقدم لكم اياها دكتور احمد شاكر. راح يعرض لكم الكيسات وحالات شويه نفس هاي اللي عرضناها حتى تعرفون مثلا شلون تشخصون الميجر. بس بهاي المحاضره بس نسولف شنو يعني كاب وشنو يعني ديسك وشنو يعني بلاد فيسل. فالمحاضره انترودكشن اللي ما راح تشوفوه ليتر اون. فشكرا لسؤالك وكلامك مضبوط.
دكتور بس من خصتك.
نعم. قل لي اسم حضرتك لانه هاني ما دباو على اسمه.
امين قاسم.
يلا امين.
دكتور بس مو نسوي جروب بس عامله ساعه رافع ايدها، بس هي جزء المشكله بالمايك فما نقدر يعني تحكي، فهي موجوده مسوي ريز هاند.
زين هي اوكي مسوي ريز هاند. اني what can I do
عمود الحضور
to make her with us.
جزء لها مشكله بعمود الحضور، يعني خطيه هي حاضره.
اوكي خلي تكتبي بس يعني اني اوكي
لا تحكي بس تشوف اكو يعني
نعم
بالمايك.
اوكي نعم اوكي ماكو مشكله بس انا بس اريد اعرف شلون تقدر تجاوب على سؤالي حتى انا اعرف هي حاضره ويانا. هو اكو واحد يقدر يحضر وطبعا يسد المايك وهو يعني مو يعني، فشلون انا اعرف؟ بس تعطيني في الطريقه حتى انا اعرف هي وياي. اكو فد خانه انه احنا نكتب بيها، انا حقيقه ما اعرف، انت احسن من عندي.
نعم دكتور اكو خانه مال مسج
اللي هي chat with everyone، مو صحيح؟
اي chat with everyone. نعم دكتور.
يلا آمنة تكتب لنا، فدخل تكتب لنا، نسألها سؤال وتكتب لنا.
دكتور بس نتواصل وياها ثواني.
يلا امين. هاي آمنة. زين وجعفر وينه؟ جعفر ماكو، جعفر عبد الوهاب. يلا شكرا لكم. اللي ما عنده سؤال هي كان لي. شكرا، خلص السيشن. احنا نبقى بس اني وامي اوف يو هي كان ليف. يو ار فري. ثانك يو فور اول. ثانك يو فور يور اتنشن. كلش اشكر. باي باي. نشوفكم ان شاء الله يوم الاحد. اني ون اوف يو هي كان ليف. بس احنا نشوف
دكتور
امنه،
عفوا
نظل
سؤال.
احنا وامنه وامين. نعم قولي لي اسمك.
دكتور بس بين ما آمنة تجي، بس كان عندي سؤال. أنا اسمي أمنية.
اي يلا اساليني انا اسمعك.
دكتور بالسلايد مال الفندس اند ديسك قبل الاوبتيك ديسك اديما.
انت امنيه. يلا امنيه اسمعك. نعم.
اي دكتور، هاي الصورة كانت هي الوحيدة اللي لونها ازرق الديسك. هاي هنا احنا ايش حاطين بحيث هيجي؟ يعني احنا ماخذين بس انه اكو داي اللي هي الفلورسين تسويه ازرق، بس ليش حطيناها؟ يعني هنا هذا هو الديسك نورمال.
اوكي هسه نطلع ماشي.
ايه هي هاي
وياي هاي
دكتور؟
الصورة تقصدين؟
اي هذه، لانه قصدي ليش لونه ازرق والبقية كلهم يعني سواء مبين هنا اللايت ريفلكس.
وين اللون الازرق؟ بس تقدرين تقولي لي قصدك باطراف الصورة؟ اطراف الصورة لونها ازرق؟
ايه قصدي، ايه هو قصدي احنا هنا حاطين بحيث تختلف عن البقية.
شوف شنو دكتور طلع؟
دكتور ايه طلع.
الظاهر اي يمكن. بس الآن تكتب شو يسموه؟
اعتقد راح ينقرأ.
يا سخيف. سديته والله. هاي شي قاعد يطلع من يمه. يلا بعد شو اسوي له؟ يمكن اجي. وجه؟ لا. ترى آمنة ما سمعت، عبارة عن شيء لو تبدلين الهيدفون شيء تحكين بالمايك مال التليفون مباشرة نسوي على السبيكر. دكتور الو.
رجع الدكتور أمين.
ايه بس مو فيها شيء. دكتور إبراهيم.